You might not have time to go do a colonoscopy, but I bet you will find time to get chemotherapy. And he was diagnosed with stage 4 colon cancer. He said, because my friend ignored his symptoms and had colon cancer. Welcome to your daily health briefing. I'm Dr. Albert Takem. This show is here to help you navigate the complex U.S. medical system, one step at a time. Whether you are decoding a new diagnosis, fighting for a referral, or just trying to stay informed, you are in the right place. Let's get into the science. So my patient came to see me for his 6-month follow-up. And the first thing he told me when I walked into the room was, "Doc, I am so happy you asked me to go do that colonoscopy last year." So I asked him why. He said, because my friend ignored his symptoms and had colon cancer. So I said, tell me a little bit more. So he told me that his friend had been experiencing constipation for several months, but ignored the symptoms and finally decided to go see a doctor 4 months after, and he was diagnosed with stage 4 colon cancer. Now this story broke my heart for a simple reason that I will tell you in a few minutes. But the patient told me that his friend did not get his colonoscopy, and he was 7 years past the recommended age for colonoscopies, which is age 45. Now, the reason why this is tragic is because colon cancer is an entirely preventable cancer, and I will explain to you why. Colon cancer in most cases starts as a polyp. That polyp starts as a mutation, and we have known in medicine that colon cancer has a very predictable life cycle. Matter of fact, it's one of those cancers that we've literally studied from the beginning to the end, and we have found out that it takes 10 years to go from the mutation that causes the polyp all the way to colon cancer. That is why in most cases, if you have a clean colonoscopy, they will tell you to come back in 10 years to get another one. Now, why do we do that? Why 10 years? And why in some cases 3 years or 5 years? Again, it goes back to what I was telling you earlier. Colon cancer starts as a mutation. The mutation causes a polyp. The polyp can be of different types, and based on the type of polyp, the number of polyps the gastroenterologist finds when he does your colonoscopy, the distribution, the location, the type of polyp found when they do the pathologic analysis, that is, when the pathologist goes under the microscope and looks at the tissue, they tell you your risk and how soon you should get the colonoscopy repeated. Now, this is powerful because other cancers that we do screening for, we tend to look for them when they are still small and treatable. For instance, women get a mammogram every year or every 2 years. We are looking for early stage cancer so you can treat it. Same goes for pap smears. When women get pap smears, we're looking for cancerous cells or cells that are looking like they could become cancerous. So part of the cervix can be removed before it turns into cancer, or you can do other procedures to remove those cancerous cells. But not so with colon cancer. Colon cancer is preventable because we are looking for polyps so that they can be removed and you can prevent cancer. Isn't that fantastic? That is literally the only cancer you can prevent by removing things that can become cancerous. That is why colon cancer screening is so potent, and that is why my patient's friend's story is so tragic, because he wound up with a cancer that can be prevented. And we have excellent screening protocols for colon cancer. At age 45, you get a colonoscopy. If a first-degree relative had colon cancer earlier than 45, you start screening 10 years from that index case. These protocols are well established and have been shown to save lives. But here comes in the biggest problem. Most of the time, patients are not compliant with recommended care, and secondly, doctors do not enforce screening. And I will tell you exactly where we doctors fail our patients. But before we get to the doctors, let's talk a little bit about patients. Listen to the things I hear all the time. Doc, I really want to do the colonoscopy, but I don't have time. I always tell my patients, Susan, you might not have time to go do a colonoscopy, but I bet you will find time to get chemotherapy. It might sound alarmist or tragic, but these are things I see in the clinic every day. Patients tell me other stories like, Doc, I don't want to do the colonoscopy. The last time I did it, I took that awful substance and I pooped all night. And I told them, listen, Jamie, you took that substance so that you can clean your colon. So when the gastroenterologist goes in with his camera, he can get a clear view of the walls of your colon and see if there is any cancer or polyps. It is worth pooping all night. Now, to that point today, there are other things that we give patients to prepare for a colonoscopy. Just ask your gastroenterologist what other options exist. You have things like Suprep, which happens to be the one I used when I got my colonoscopy, and it can also be used for colonoscopies. Another thing I hear from patients all the time, Doc, I am afraid of anesthesia. I don't want to be put under. Dear friend, listen, when you get a colonoscopy, it is not major anesthesia. It's not like you're going for heart surgery. Listen, I could have driven myself home, but the protocol says I have to have somebody else drive me home. So I got someone else to drive me home. But this anesthesia is light. They wake you up and you go home and you don't have to worry about anesthesia. Another thing I hear from patients all the time is, Doc, can't I just do the stool study, the one they send there in the mail? It's called Cologuard. And I always tell them, if your Cologuard is positive or any other stool test is positive, you still have to do a colonoscopy. But guess what? All those stool-based studies do not look at your colon. They cannot remove a polyp. We do not do colon cancer screening to look for colon cancer. We don't advise you to get colonoscopies so that we can find cancers. I send my patients to get colonoscopies so that the specialists can find polyps, remove them before they become cancerous. That's the trick. That is why, let me tell you a secret. Just between you and me, doctors always get colonoscopies. They never get stool-based studies because we know the truth. It is better to walk out of the colonoscopy with certainty that you have a lease on life for another 10 years, at least when it concerns colon cancer, than to do a stool-based test and wonder if you are really okay. That is why physician allyship matters. That is why you have to find a doctor who wants you to get the same care that he receives. That is why you have to make sure as a physician that when you're telling a patient to go get colon cancer screening, you're making sure the patient understands that we are not screening to find colon cancer. We are screening to find polyps so they can be removed and so the patient will not develop cancer. Now, I wish many more doctors, both primary care physicians and gastroenterologists, will hammer on this point, will focus the attention of the patient on this distinction. Colon cancer is the only preventable cancer we know about. and it's the only one that to prevent it, you need a colonoscopy. All other stool-based studies for colon cancer screening look for cancer. Some of them look for polyps, but none of them can remove the polyp. And just in case you were wondering, the reason why this is important is because colon cancer is the second leading cause of cancer death in America, and it is very preventable. If you are 45 years old or more, schedule your colonoscopy today. If you are a loved one of somebody who has not scheduled their colonoscopy, call them, talk to them, let them know how important this is. You just might save a life. Do not wait for symptoms. Get your screening today. This has been the Daily Brief. Medicine is not about certainty. It is about responsibility. Decisions are often made with incomplete information, but they are always made with your safety in mind. In a system that can feel rushed and fragmented, you deserve clarity, continuity, and an advocate who sees the whole picture. I am Dr. Albert Takem, your physician ally, high-level science, human-level care. I will see you at the next briefing, or I will see you in the clinic.